If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? It's your man, Dr. Kyle. Welcome back to the Driven Athlete Podcast. This topic I am a little more passionate about, and I like to nerd out on this because this is something that I've battled throughout my athletic career, mainly in college and post-college, just trying to be active, athletic, and really, maintain my high level of health and wellness as best I can. So knee pain, patellofemoral pain, patellofemoral syndrome, that's the topic that this is about. And like I said, I like to nerd out on this and really figure out as much as I can and work with patients on this and live vicariously through making their improvements because I battled this and nobody had an answer. It's a bummer. So patellofemoral pain is pain right under the kneecap, where it feels like there's grinding or pressure right under the kneecap, where the patella is your kneecap and it grinds against the top layer of your femur surface. So the surface of your femur, which is your thigh bone, and your kneecap glide and grind against each other like this, which is appropriate and totally fine. But if there's unnecessarily pinpoint pressure and grinding on one surface versus another surface, it's not distributed well enough or evenly, then it can cause knee pain. It can cause intra-articular knee pain, and specifically pain that feels like it's under the kneecap or just around the kneecap, just the perimeter of the kneecap. And it usually hurts with stairs, squats, lunges, jumping, plyometrics, agility drills, acceleration and deceleration moments. Those are all pretty classic provocative movements that is going to elicit this kind of knee pain. So this is for people that are athletes and active people where they're like, I don't know what I did, but my knee just started hurting. It just hurts when I do this now. And it's been going on for it's gotten here and there over a couple of weeks, couple of months, and now it's more pronounced and it's definitely a little more irritated and it's easily provoked. So like, what the heck's going on, right? So if that's the case, patellofemoral pain syndrome, patellofemoral, and that's the kneecap on the femur, on the thigh bone. And like I said, the grinding of your kneecap, the retropatellar compression is necessary and normal. Underneath the kneecap, retropatellar compression and grinding against your thigh bone, your femur, is appropriate and necessary. That is how your joints actually get its nutrients, is a little bit of compression and pressure on purpose. That imbibes is the term that's used. It absorbs and soaks in the fluid, the nutrients from your synovial fluid that helps to lubricate the joint and then also deliver nutrients. Okay, so it's important and necessary. Over time, with an appropriate amount of that, it actually fortifies and improves and solidifies your articular cartilage over a long period of time through subchondral bone growth. So that's what the research suggests, and some evidence is purported, which is very interesting. But with how do people develop this and how do we fix it, right? That's what people usually ask. Why is the problem happening? What's the painful tissue and how do we fix it? Those are usually questions we get. So there's two reasons why this type of pain usually develops, from my opinion, okay, from things that I've seen. It's usually an instability issue of the knee that can alter the angle of trajectory and pull of the kneecap, that can put pinpoint pressure on the undersurface of the kneecap when it bends and flexes and extends with a lot of pressure. And then also not the best inferior glide of your kneecap, of your patella. All right, inferior meaning low, so going down. So if the kneecap needs to glide downwards as you bend your knee, if it's inefficient and not well enough, then that can cause more pressure on the undersurface of your kneecap and cause pain, right? So imagine when somebody uses their quad muscle and they do squats and their leg muscles, all those things, and everything tightens and compresses the joint. Imagine squatting 225 or 315 or 400 pounds. There's a lot of pressure against the kneecap backwards against your thigh bone. Like I said, it's normal and appropriate. If it's not seated in the right position or the angle of pull isn't accurate and appropriate as it could be, it's going to put pinpoint pressure and rub one surface more than other surfaces and not distribute it evenly, and that's going to cause pain. So there's a ton of pressure against the back part of your kneecap with squats and lunges. Like I said, loading it a ton, it's going to increase that pressure even more. So, and that is what exposes the grinding feeling, the clicking, the popping, the crepitus is what that's called, and also pain, of course. All right. So why does that pain come? Either instability of the knee or not the best inferior glide of the patella going down when you squat. So either way, that causes retropatellar compression of the patella on the femur underneath. So I mentioned crepitus. Crepitus is just, it represents roughening of the articular surfaces against each other, okay? And increased fluid and edema, swelling in the joint, inflammation, all right? So it just suggests more fluid in the joint for more popping and clicking, and then roughening of the articular surfaces. As things continue to progress and get worse and worse over time with patellofemoral pain, knee pain like this, and it gets worse with squats and lunges and jumping and stuff. Chondromalacia can then be developed and in turn will happen, but that's not necessarily the end game or like, oh, then you're screwed, right? That there's plenty of people with chondromalacial type of changes in their joints, especially in the knee. It's very common, and they're pain free. It just is crunchy, right? Their knee's just crunchy from the crepitus. That doesn't indicate success or failure because the body's really resilient. And like I said, things can get better and improve even with chondromalacia. I know it's controversial. I'm just saying what the empirical evidence suggests, okay? That with non-painful movement and exercise to purposely compress your joint, not at a painful level, but sub-pain threshold over a long, long period of time. I'm talking about like 8 to 18 months worth of time of not effing it up over and over again and doing too much compression. That actually helps to fortify and solidify articular surfaces, meaning your retropatellar cartilage and also the trochlea of your femur cartilage where they grind against each other. So it's interesting, right? So what we look at is why did this particular person develop this kind of patellofemoral knee pain in the first place, right? Like, what are they doing differently? We have to address the compensation patterns, the compensatory movements, the mobility disparities, the range of motion and joint mobility disparities of the hip and the ankle and the knee, and then also the stability issues, which is usually recruitment. What muscles are being recruited more than others? Dominant muscle tissue or muscle groups, and then less dominant muscle groups. The more dominant ones are going to overpower and they can affect and alter the joint mechanics and the biomechanics of your knee. So we have to even out that disparity in what muscles are being recruited over and over again and make it easier for the less dominant and the less recruited muscles to be activated and used better. And they can contribute to the movement that then decreases that disparity in movement and compensation patterns. Same thought with joint mobility. If some joints are very stiff and just inherently don't move as well as they could move, and other ones maybe are taking the brunt of the movement, we have to even out that hypermobility and hypomobility and create less disparity between them, and that evens out the playing field for less compensations. All right. So as a manual therapist, that's what we have to do. We have to, number one, diagnose the issue, like where these compensation patterns lie for this particular athlete or active person, because it's different. And then where can we intervene, right? Typically, we find ourselves intervening at the ankle. We have to get the ankle to dorsiflex and bend backwards better. Dorsiflexion is when you bring your ankle up or your toes up towards the ceiling. Your ankle needs to bend enough into dorsiflexion to bend that direction in order for your knee to not have as much pressure through the retropatellar surface on your kneecap. The second thing we find ourselves mobilizing then is the soft tissue that connects to your ankle, which is your calf. The triceps surae is what that's also called. Your soleus, your medial and lateral heads of your gastrocnemius. All right. Your gastrocnemius is your calf. Your soleus muscle is a muscle underneath the calf that is very high dense in type 1 fibers for long distance runners. Random, but those connect into your Achilles tendon, to your calcaneus, your heel bone, and that can limit and check dorsiflexion range of motion. So there could be soft tissue restrictions and also joint mobility restrictions. All right, so we have to fix both, right? Cool. So we'll mobilize the ankle. Manual therapy, we'll manipulate the ankle joint, the talocrural joint, the TC joint, if it's appropriate. We can look at the subtalar eversion. We can look at arch collapse, medial longitudinal arch collapse if it's pronating and collapsing too much. And we can try to normalize the mechanics as best as possible. And then we have to intervene at the soft tissue behind it, which is usually the calf, all right? The Achilles, the soleus, and the calf. So that's all collectively called your triceps surae. So we'll strip that, we'll scrape it, like Graston as an example, cup, and then dry needling seems to be a great game changer for that too, which we've talked about. So once we get the ankle moving better and the calf moving better, then we can look at the hip. And usually for this, posterior hip capsule mobility is limited. So it's like, how well can your hip bend backwards, bring your knee to your chest without any compensation patterns happening through the hip joint. If it's lacking, then it's going to make your body shift forward more. You're going to have more lumbar spine shearing, and it's going to put more brunt force through your knee. Does that make sense? So where are the two most common places with squats? or lunges or step ups or Bulgarians, rear foot split squats, rear foot elevated split squats. People usually have pain where? Right in the front of their kneecap or in their back. Where are the two most common places that's going to overcompensate and make up for that? What I just said biomechanically, the knee and the low back. It makes sense, right? So we can intervene to stop that from happening. Like there is a solution, right? We can work on this stuff. Not just like, well, just rest. Just ice and take some Advil. It's like, that's not going to solve any problems. It'll make things temporarily not hurt when you just like live your life. But if somebody has aspirations or desires or goals to like squat and exercise again, or do lunges and step ups and plyometrics and have fun with their kids in the yard or whatever, run on the beach, run a marathon, stuff like that, then they have to address these compensation patterns. Otherwise, if they rest, things will feel better. But as soon as they get back into their activity, if they didn't fix the compensations, the symptoms are going to come back again. We didn't fix the actual underlying reason why the pain started in the first place, which is usually this system of dysfunctional biomechanics. All right, we call that a movement system impairment or a movement system dysfunction. There's a lack of hip mobility in the posterior capsule. There's a lack of ankle dorsiflexion, range of motion, and the kneecap isn't gliding inferiorly efficiently enough. And all that combined collectively makes more retropatellar compression against the femur as it grinds up and down when someone bends their knee joint like this, okay? And that just creates symptoms and pain. Over a long period of time, we get a lot of articular irritation and inflammation and swelling and fluid and roughening of the surfaces, and that causes clicking, popping, grinding, crunchiness in your knee joint, and pain, of course, right? So with that being said, hey, cool, we can fix that. And like I said, the reason why I'm even passionate about this, why I like to nerd out on this stuff, is because this is what I battled all through college. Playing volleyball and football. I was a two-sport athlete in college. My freaking knees always hurt. And then we could figure it out. Like it just hurt right under my kneecap. And I'm like, man, do I need surgery? You know, is there like bone particles that chipped off and I'm just rubbing against my knees when I squat? Or jump and land and stuff. And I'm really like, man, I wish I would have had this kind of approach when I was an athlete playing sports, and I wasn't able to get any kind of help or solutions with this, like actual active concrete solutions and action steps towards fixing the problem. Where it's like, if you intervene with this stuff, imagine over a couple of weeks, if we normalize these things, get things to settle down first. Of course, the number one thing is you can't F it up over and over again. You have to let things settle down. Intervene and implement some of these solution strategies, work on the soft tissue, work on the joint mobility, definitely work on mechanics. Like you have to fix your jumping mechanics, running mechanics, squat form, lunge form, all those things. We can fix that stuff and improve the mobility, the functional range of motion mobility requirements. So improve the form and mechanics and coordination. All that stuff combined over a couple weeks, it would be unreasonable to think that an active, athletic, healthy, otherwise person wouldn't get better. And we're living truth. Like we do this all the time with our patients. So I'm just excited about it and passionate about it because we live vicariously through our patients. Like, dang it, wish I had this when I was in college. So I was like, hey, I'm going to share this with you so you can avoid all the frustration, pain, and limitations that we've battled, right? Me in particular for this topic. But anyway, so the patellofemoral pain is a really common thing. Here's what doesn't work. Talking about what's going to solve the problem. Right? Why did the problem come in the first place? And how can we solve it and prevent it from coming back in the future and implement now so you can get back into your sport and your activity and not be frustrated? What doesn't work? Unfortunately, rest, okay, isn't going to solve the problem. It's going to stop effing it up. Cool. But rest leads to rust, and it's also not going to fix the underlying compensation patterns. We're all about modifying your activity, but we're not going to tell you to rest. Rest isn't going to solve anything. It's going to help decrease a lot of the inflammatory and heightened irritating factors for sure in the moment for like a week, right? Maybe 2 weeks. But at the same time, it's like for an active person that speaks the same language, usually what we hear is, I'm driving myself crazy. I'm not doing anything. This sucks. I don't know. Like I can't do anything right now. I've been resting and I'm ready to just do whatever I want to do. So after that deprivation, it usually leads to binging, right? So 2 weeks later or 10 days later, like my knee feels fine. I'm F it. I'm going to do whatever I want. I'm going to just get back into it 100% hardcore, all go. And then guess what happens? The symptoms come back. And then they get really frustrated and it hurts, right? So they go back to the doc or their primary care doc or the orthopedic surgeon, whatever. And they're like, well, here's this x-ray and MRI. It's showing these structural changes. You have a meniscus involvement too. Your meniscus is torn. It's like, dude, that's been torn for a long time. That's not the reason why your knee hurts. I know it's also controversial, but there's plenty of people that have frayed or torn meniscus evidence on imaging and MRI, but they have no symptoms. They have full range of motion and no pain and full functionality. So with that being said, do we need to intervene with that structure? That's not really the issue. Temporarily, things are lit up right now when we know that. But why, right? Is it an instability issue, patellofemoral pain related? And we can diagnose and work through all these factors that might have led to the pain in the first place. Anyway, I digress. So 2 weeks go by, these active people that are super motivated and amped want to do stuff and exercise and work out. They can't, they don't do it. They're getting crazy. They're stir crazy. They're getting cabin fever. They're frustrated. And they're like, F it. I'm just going to go out and do what I want anyway. And their knee gets all lit up. Then they get really frustrated. Then they don't know what to do. And then it comes back. I'm like, well, we want me to rest again and just ice? I'm tired of doing that. That's right. So they rest again, and then they go back and doing their activity again, and it hurts again. So this is the same cycle that we've noticed with people a lot for weeks and months, right? Even years. There's people years. Like I've been on and off knee pain for 2 years, 9 years, right? It's like, it's clearly not working. Something's not working. Like if nothing changes, nothing changes. Let's put some mental effort and dive into the matter. Okay, let's dive into this and rectify this problem, right? And like I said, we'll be the first ones to refer out, but there is a solution. For active athletic people that have non-traumatic knee pain that just came out of nowhere, my knee just started hurting 3 weeks ago or 3 months ago, whatever. There's a reason why it started to hurt. It's just getting overloaded and overwhelmed because of these compensation issues, and we can address that. Cool, problem solved. Just have to understand that, be aware of it, and also buy in. Be like, I'm in. Let's do this. All right, let's fix this problem and not take the short route, which is the other thing that doesn't work. Advil and just NSAIDs, right? Anti-inflammatories over the counter. Non-steroidal anti-inflammatory drugs, which is like Tylenol, Aleve, Advil. Of course, it's going to make you feel better. It's going to take the edge off the pain. But is it solving the underlying problem? That's what I'm asking. Is it actually solving the compensation patterns that led to the problem, the pain in the first place? No. So we're icing also, and that's the other thing that really doesn't work, which is interesting in the research. Ice, I don't hate it. It's either way. The main question I ask patients is, do you like it? When you ice, do you like it? Do you feel better? Do you think it helps? Yes or no, that's the determining factor. Unfortunately, in the research, the validity behind ice is pretty weak, as in like the validity being, does it do what it's purported to do? Ice is purported to decrease inflammation or prevent inflammation. Does it actually do that? According to the research, there's mild to weak evidence to support that it actually does it. So with that being said, are we going to spend a lot of time and effort prioritizing and emphasizing ice to solve your problem? Probably not. If you enjoy it and you like it and you feel like it helps, go get after it. Have fun. Like, do it. I enjoy ice baths personally. Like, I think it helps me. We can't ignore that athletes and active people, we can't separate the mind from the body. And there's a psychological component with being athletic and active, of course. So if it's part of your routine and routine-based and you always feel better with ice, dude, do it. It's not going to hurt you. But at the same time, at like 3 o'clock in the afternoon, randomly, you've been watching TV, you're hanging out, resting, and then it's being like, you know what? I have an ice today. I'm going to ice right now for no reason. That's not really going to help anything, in my opinion. Like I said, I'm only going off what the empirical evidence and the research suggests. The other thing to consider with that is we know it's a constriction. It's a constrictor, right? Ice, it helps to constrict capillaries and blood flow. It also helps constrict all the other fluid vessels and blood vessels, like your veins and your lymphatic system, right? So the thought is, if you sprain your ankle, slap some ice on there right away, and it helps prevent a huge influx of edema and inflammatory fluids response into the joint, so it doesn't blow up as much, right? An inflammatory response is necessary. It helps with immune response and repairing tissue, of course. But ice might help prevent an overreaction of that and an over-inflammatory reaction by preventing a lot of fluid from diving into the joint and beelining for the joint. So the thought is, like, within like 24 hours, if you put some ice on for 20 minutes, it helps prevent that overreaction of inflammatory responses because it constricts the blood vessels and the fluid vessels. So with that being said, if somebody emphasizes ice and they ice all the time, randomly during the day where they haven't really exercised or moved or sprained or like overly strained something to prevent an inflammatory response being overly reacted, and they just ice randomly, You are constricting the blood vessels, but you're also restricting the lymphatic return. Lymphatic vessels being like the lymphatic fluid return that helps get fluid out of your joints and out of your body to excrete it out. So you're constricting that. And you're also constricting the venous return, your veins. Veins also return blood flow out of areas, away from your body into your heart, so you can excrete out the waste products again too. So you're restricting lymphatic vessels and venous return vessels, which actually might help keep fluid in the joint. Just food for thought. So with that being said, I'm not going to overly emphasize and prioritize ice randomly through the day. So ice baths are also controversial with this stuff too. I'm a fan of ice baths. I think it's super invigorating, and I like it. It's challenging. It's a mental challenge. That's one of the biggest benefits I think it comes from, is just being able to overcome your mental resilience and toughness, because it's uncomfortable. But there is some evidence to support there's a neurological response and an endocrine hormone response that helps with body inflammation and just reacting a better resiliency for the body in an inflammatory response. So there is evidence to support that, which is cool. So I like ice baths. I'm cool with that. If someone's going to ice, I'll be like, do an ice bath instead, if you're cool with that, if that's what you like, right? But anyway, so with all that being said, here's what doesn't work to sum this up. Anti-inflammatories, ice, rest, and the other ones are bracing and KT tape. Bracing doesn't really help with avoiding these compensation patterns from developing. It doesn't solve the compensation patterns in the first place. The thought being that the brace helps keep your kneecap in a better line of trajectory and pull to prevent it from like going in and out and being unstable. There's weak evidence to support that actually that's what it actually does, that because there's so much pressure and tension between your muscles and tendons. And like people, like, you're strong. It's a strong joint. An external brace doesn't prevent that from happening, unfortunately. Okay, and then KT tape is an elastic tape, kinesio tape. Thought that if you tape around the perimeter of your kneecap, it helps improve the angle of pull of your kneecap. Same thing. It doesn't. The evidence is very weak to support that from the empirical evidence. So I'm not as a practitioner, when somebody comes with knee pain, prioritize that. But like, you know what you need? We got a KT tape. We got a brace. Ice it every day, right? And rest. Just real quick. Oh, and take anti-inflammatory pills. Real quick, if you do see, what kind of practitioner do you think do you hear that very often? There are practitioners that we hear recommend like solution for your knee pain, those things. Brace, tape, anti-inflammatory meds, like over the counter, ice it, and then just rest. I'm just saying. So with that being said, what can we do to solve the problem, right? What solutions do we need to do? We need to take a deep dive into what actually caused the problem in the first place, okay? And the compensation patterns and everything we mentioned before, the joint mobility mechanics and the biomechanics. The other thing we need to work on, if it's an instability issue, is we definitely need to work on the knee dynamic stability. Okay, if the stability is compromised and it's not as stable as it could be, and handle the load of like landing, jumping, deceleration, acceleration, box step-ups, plyometrics, all that stuff. If the knee is set up for failure to be stable through that intense ballistic loading, then it's for sure going to get affected, right? And the angle of pull of your kneecap can be affected, and it can be unstable. So if it's unstable, then some of the tissues, the tendons, ligaments, and joint capsule that surround the knee joint are going to get overwhelmed chronically, rep after rep after rep after rep. So think about like a marathon runner, endurance athlete. How many steps do they take in their marathon, like their running training? A ton, right? Thousands. So every rep, every single time, there's compensation patterns that happen, and the tissues that are trying to overstabilize that can't, or taking the brunt of that load and tension, are getting irritated over and over again every single time, right? So, and with athletes that are runners and exercise a ton, over and over again, if there's an instability issue, the surrounding tissues are getting overwhelmed, and that's where sometimes the pain comes into. All right, so we would still call that patellofemoral pain, and the solution for that is a little bit different than somebody with lacking inferior glide of the patella. Okay, for mobility. So it's an instability issue, and we're going to definitely change that. So we have to work on coordination of movement, recruitment, Dynamic stability, especially through ballistic movements. All right, we have to break that stuff down. Like we have to get to work with the roll our sleeves up and get in there and fix these biomechanical issues. Okay. Manual therapy is a great way to work on that too, to set things up for success. Okay. We can set the joint up for success to move better. And then since it's moving better and the soft tissue restrictions are relieved a little bit, now it's time to exercise and work on the compensation movement patterns and recruitment patterns of muscle tissue to keep everything as stable and even the playing field of these compensation recruitment patterns and movement patterns as best as we can. And over a couple weeks, when working on that stuff, then we can wean back into more challenging and aggressive, ballistic movement, powerful movements where the knee can handle it now. And it's not going to dive right back into those compensation patterns again. Because athletes are the best compensators. We can't neglect that, okay? Athletes are the best compensators, and just get the job done, they'll get it done. They're really good at learning movement patterns to get the job done. So we have to unlearn some of the movement patterns that cause the issue and then learn new ones. And that's part of the corrective exercise component, all right? The corrective interventions and manual therapy really sets it up for success for the joints to move as best as they can, okay? So the corrective exercises is what really solidifies the change that we're looking for and really solidifies the movement impairment issues that led to the problem in the first place. Does that make sense? So if you have any questions, we can definitely chat, especially in the knee pain topic. Like I said, I nerd out on this stuff and I'm super passionate, especially for young athletes or just active people, of course, and athletes. It's just something that I battled with and I'm like, man, I wish I would have had this understanding of, or at least somebody that would have understood this and gotten the treatment and implementation of these things to help fix it so I could keep competing at a high level. But I just did anyway. I just took Advil and just powered through. But at some point, the chickens are going to come home and roost, you know what I mean? And it's going to be an issue that is going to be more of a challenge. So for like a longevity standpoint for our aging athletes that are, wanting to stay a high vitality, mobility, longevity, and for health and wellness activities that they enjoy, but also is going to be good for their life and their body and their physique and their confidence, all those things, and their health and wellness. These are the kind of things that we really have to dive into. So if you've been battling knee pain or knee issues, around the kneecap, definitely reach out. We love to chat. Okay. We help people with this all the time. If you have any conflicting opinions, other suggestions, or other suggestions within this topic, man, definitely reach out. We're always open to having a discussion. Man, we're open-minded. I've always thought that people who are aware and educated in certain subjects that are open-minded, educated individuals have great conversations. Closed-minded, educated people, usually a higher ego, not as much humility, that leads to a power struggle and not really a great conversation. That leads to one-upping. If you've ever been around this, this is my own little thought on that. So usually a power struggle, one-upping type of conversation versus an open-minded, great conversation. But anyway, I try to be as open-minded as I can be, man, because I want to be aware and learn as much as I can and help people. I'm not saying I'm awesome or the best at any of this stuff. I'm just sharing things that I've learned that I like and nerd out on. But anyway, so definitely reach out if you have any questions. If you want to call us directly, our best number is 561-899-8725, or you can email us at team@athleterc.com, TEAM@athleterc.com, and we'll catch y'all next time.